Bien, invitamos al doctor Savillón y a su esposa a que hagan uso de este podio.
Bien, es para mí un honor la presentación de un speaker de la categoría de George Papacostas. Papacostas es profesor asociado de psiquiatría de Harvard Medical School y director del Departamento de Depresión Resistente de Psiquiatría del Massachusetts General Hospital. También es editor de campo de la psicofarmacología de la Mundial de Psiquiatría Biológica y miembro del consejo editorial de la revista Psychiatry Research. El foco de investigación del Dr. Papacostas incluye la farmacología del trastorno depresivo mayor, incluyendo la depresión resistente al tratamiento, el estudio del efecto placebo y su importancia para el diseño de ensayos clínicos del trastorno depresivo mayor. Ha recibido numerosos premios nacionales e internacionales de investigación, incluyendo el Colegio Americano de Neuropsicofarmacología, y es autor o coautor de más de 150 publicaciones clínicas y científicas. Resumiendo un poco el currículum del doctor Papacostas, debido a lo avanzado de la obra, yo puedo decir que vamos a presentar uno de los grandes investigadores que tiene su punto fuerte en las áreas más difíciles del tratamiento de la depresión, a la depresión bipolar y las depresiones resistentes. Tiene el mérito de haber publicado quizás en las 4 principales revistas norteamericanas: American Journal, Journal of Clinical Psychiatry, Journal of Clinical Psychopharmacology y Biological Psychiatry. Nunca pensé que iba a tener el honor de presentar a un expositor de su categoría. Como ustedes, es una persona, como ustedes ven, joven, ha aportado mucho, pero le queda mucho más por aportar debido a su juventud y a su productividad. Papacostas ha dado más de 100 charlas magistrales en más de 30 países. Los dejo con una de las personas que más admiro y que más sigo, profesor Papacostas.
Thank you, Professor Savillon, for your kind introduction. I'd like to thank you, of course, as the audience, for being here on such a beautiful day. GlaxoSmithKline for their kind invitation, thanks to whom we have this talk available today. And of course, the two societies that organize this talk. So it's my first time to be here in the Dominican Republic, and it's a big pleasure for me. So let me see if we can back up on this slide, please, to the first slide. Now, before to the first one. My first slide with the name and title. Yeah, from the beginning. Thank you. so let's get started. So I think this is the best place where we can begin. The question is, in the treatment of major depressive disorder, how effective are the antidepressants that we use? So these are the results of a meta-analysis that we conducted back in 2009, looking at all randomized, double-blind, placebo-controlled studies of antidepressants for major depressive disorder. And I think there's several things that are interesting here. The first thing that's interesting is the obvious, that antidepressants are better than placebo at treating depression. Okay, so that we know from our clinic. You know, it's if you do nothing, patients are less likely to get better than if you do something. The second thing that's important is that antidepressants only treat, if you use one agent, it's only going to treat some people. So we're going to have to follow up and do a lot of things to get people better. The third and the most interesting thing is this one, the placebo response. The placebo response, as we know in depression, is not low. It's 36.6% on average, 1 in 3 patients. So what does this mean? This means that aside from knowing all the drugs that we should know, and knowing all the psychotherapies that we should know and all of that, being able to relate to the patient is a very powerful way of getting the patient better. So providing hope, going against pessimism, these are all things that are as important as the drugs we prescribe or the psychotherapy we prescribe. Now, antidepressants also don't work equally well for all symptoms of depression. So this is a slide showing common residual symptoms of depression. As you can see from this slide here, sleep disturbance is one of the most difficult symptoms to treat with SSRI antidepressants. That is, sleeping too little or sleeping too much, followed by tiredness, diminished interest or pleasure, guilt, and poor concentration. If you see here, these are SSRI remitters, people that remitted with fluoxetine in this case. Even though they're in remission, 45% of patients have sleep disturbance and 40% complain of tiredness. What kind of remission is that? If 40% of patients are saying they're still tired. Now, if you look at how refractory symptoms are, we ask the following question of this database. If you have a symptom of depression that's present, how likely is it that it remains present after a patient is in remission? 70% of people that present with depression and say that they sleep too much will still complain that they sleep too much after the depression is in remission. Okay, 35% who present saying they're tired when they're depressed will still say they're tired after you treat them with an SSRI antidepressant. So again, the question is, what kind of remission is this that we're talking about? Or, in other words, can we do better in terms of treating these symptoms of depression? Another way to look at it, this is another data set, again, the same thing. We have people that got better with antidepressants. 34%, 39% said their motivation is not what it used to be before they became depressed. 41% say it's hard to stay awake. 45% say they're tired. About 10% of these say that this is a severe intensity. So again, we talk about remission and depression, but are we making sure that whatever residual symptoms are there are treated successfully? Why is it important to get rid of sleepiness and fatigue and depression? Because residual symptoms are associated with higher relapse rates, greater work impairment, and greater psychosocial impairment. So let's talk about lethargy, okay? Sleeping too much and feeling tired and depression. There are a number of words, in English at least, and I'm sure in Spanish as many, describing these symptoms. But if you look at the DSM, and the DSM is not the ultimate authority, it's just someone's attempt to classify mental illness. If you look at the DSM, you can't find a definition of lethargic depression. Why is that? Probably because if you define lethargic depression, there are going to be very few people who don't have lethargic depression. So this is a survey of 1,884 European patients with major depressive disorder. 73% said they felt tired when they were depressed. Another cut of this data, 76% said that their mood was low. Okay, they're depressed, you expect that. 73% said they felt tired. So tiredness and fatigue is almost as common in depression as sadness is. Sleep problems, 63%. So these symptoms, sleeping too much and feeling tired, are not found only in a small subset of patients. They're core and very prevalent symptoms of depression. Another survey gives us even higher numbers. Here, 94 to 97% of patients with depression complain of fatigue. 21% complain of leaden paralysis, an extreme form of fatigue where their arms and legs feel as if they're made of lead. If you look at atypical depression, the rates are much higher. 60% for leaden paralysis and 36% for hypersomnia, which is about 10 to 16% in the general MDD population. So the bottom line, these symptoms are common, they're difficult to treat, they stay around in remission, and we have to do better in terms of treating them. There's even data suggesting that patients who have sleepiness and fatigue, that people who have sleepiness and fatigue who don't have depression are at risk of developing depression at some point in their lifetime. So there's studies here suggesting that fatigue is a prodromal syndrome of major depressive disorder. Individuals with a history of unexplained fatigue are at increased for new onset of major depression. Here, the risk ratio is 28.4 in this study. It means that someone who doesn't have depression, who's complaining of fatigue that the doctors can't explain, has a 28% chance of developing depression over the course of the next few years. Same thing with excessive sleepiness. So it really teaches us that sleepiness and fatigue go hand in hand with the pathophysiology of depression. Now, what is the evidence that sleepiness and fatigue can be successfully treated with antidepressants? Well, we know that sleepiness and fatigue can be treated. Here we have a study comparing bupropion XL with placebo, showing that comparing bupropion XL at doses of 150 to 450 milligrams with a placebo pill in about 260 patients. So just to stop here for a moment, what is bupropion XL? Bupropion XL is a norepinephrine dopamine reuptake inhibitor that does not affect serotonin. So the idea here is that because we know that norepinephrine and dopamine are associated with the pathophysiology of fatigue, the idea here is this molecule effective at treating fatigue and depression? That was the point of this study. So this was an 8-week study where bupropion was dosed starting at 150 milligrams, going up to 300 milligrams at week 2, and going up to 450 milligrams at week 4. This is how bupropion is approved and used in the United States of America. So what kind of patients went into this study? These were patients with major depressive disorder who had an inventive depressive symptomatology score of 25 or greater. That's moderate to severe depression in common clinical terms. Now, this population was enriched for patients who had especially prevalent symptoms of not enjoying things, of feeling tired, and feeling sleepy. Okay? So they had to have a score of 7 or less on the IDS pleasure subscale that says, I'm not interested in things I'm usually interested in, I'm tired, I don't enjoy things. Now, being interested in something and enjoying something in the brain sounds similar, but are actually two different things. Wanting something often goes hand in hand with enjoying something when you get it, but not always. Decreased sexual interest and pleasure, and leaden paralysis, feeling tired and having low energy. So here are the results. Bupropion dosed up to 450 milligrams. There was a greater resolution of depressive symptoms than placebo as early as week 1 and out till week 8. This is Wellbutrin XL as monotherapy. What about energy, pleasure, and interest? There was a very robust, very strong separation between bupropion and placebo here, which was statistically significant as early as week 1, and maintained its significance all out to endpoint. So a very strong association between Wellbutrin XL, bupropion's ability to treat the symptoms of decreased sleepiness, increased sleepiness, decreased energy, and increased enjoyment in patients with depression. So a lot of these patients went from saying, I'm sleeping too much, I'm feeling tired, I don't look forward to do anything, and if my relatives push me to do something, I don't enjoy it. These are the symptoms that were targeted along with depressive symptoms in this patient population. Now, the question, of course, is, we know that some antidepressants, in this case, Wellbutrin, can treat sleepiness and fatigue. The question is, can some antidepressants do it better than others? Okay, so that's where the following data comes in. Now, why would some antidepressants be better than others? The idea is that serotonin is more related to mood and anxiety. Norepinephrine and dopamine, in addition to mood, are related to energy, wakefulness, and alertness. So we all know when we have a norepinephrine rush because if we're excited or we're nervous, we automatically are awake and can pay attention. So it's a very basic physiologic mechanism. There's also a very interesting study showing that you have decreased frontal lobe metabolism when the fatigue gets better in depression, ventral frontal lobe metabolism. Now, the medial ventral frontal lobe is an area that makes us aware of negative things like sadness, tiredness, and all these things. And when you have the metabolism decreasing in this medial frontal lobe, then you have an improvement in people's abilities to ignore these kind of things, to say, I don't feel depressed, I'm not preoccupied with depression, I don't feel fatigue. So this area is also very densely innervated by noradrenergic and dopaminergic projections. So there's plausibility as to why some of these agents can do better than others. There's preliminary evidence from the 70s, 80s, and 90s suggesting that this could happen. Everyone knows the famous story of the MAOIs versus the tricyclics in atypical depression. So what is atypical depression, as you all know? But just to review, having 2 or more symptoms of hypersomnia, sleeping too much, lead paralysis, feeling like your arms and legs are made of lead, rejection sensitivity, and increased appetite. The first 2 are by far the most common in atypical depression. They're almost pathognomonic. They almost define the illness by themselves. So we have phenelzine versus imipramine versus placebo. Here in atypical depression, a study by Fred Quitkin at the Columbia Group showing that people that got phenelzine who had depression and atypical features, or typical depression, did better than patients who got imipramine, did better than patients who got placebo. Why? We're not sure why, but one theory is that how are these drugs different? Imipramine increases brain serotonin and norepinephrine. Phenelzine increases brain serotonin, norepinephrine, and dopamine. So one of the ideas is dopamine involved as a molecule specifically in treating these symptoms of sleeping too much, feeling tired, and all that? So that is something that we wanted to test back in 2006. Up till 2006, there had been a large accumulation of studies comparing bupropion, or Wellbutrin, a norepinephrine dopaminergic molecule with no serotonergic activity, with the SSRIs, agents like fluoxetine, sertraline, citalopram, so on and so forth, comparing these agents head-to-head with or without placebo in treating patients with depression. Now, some of these studies also provided measurements through the HAM-D and longer versions of the HAM-D for fatigue, but more importantly, sleepiness. So we wanted to go back and see how many of these studies had sleepiness and fatigue measurements, and if we could see whether there were differences between bupropion and the SSRIs. So we were able to find 6 studies where we had measurements both in fatigue and sleepiness. 3 of the studies compared Wellbutrin, bupropion with Zoloft, sertraline. 1 of the studies was paroxetine with very few patients, only 100 patients. And 2 large studies comparing bupropion with citalopram and placebo. So the question was, how does it work with respect to these symptoms? Well, we pooled the data, and it turns that, as an overall antidepressant effect, so helping patients maintain remission, bupropion and the SSRIs did the same. So about 30 to 40% remission rates for both. What about improvement in sleepiness? Let's talk about improvements in fatigue first. So with respect to fatigue, bupropion did statistically better than placebo. Okay, so we saw that in the previous study. Bupropion treats fatigue in patients with depression. However, the SSRIs also did better than placebo in treating fatigue. That's something we've seen in other data sets. There was a statistically significant separation where more people who received SSRIs had a greater decrease in fatigue scores than patients who received placebo. The interesting fact was that if you received bupropion, you were more likely to have a greater decrease in fatigue scores than if you received SSRIs. So this was an important indication. You know, it was one of the first indications where we see a difference in the antidepressants in their ability to treat certain symptoms of depression. So, wow, very interesting finding here. What about sleepiness? Sleepiness is, as I mentioned before, the most difficult symptom of depression to treat with antidepressant, SSRIs, SNRIs. So, as you can see here, the bupropion group, the further down one is, the greater the resolution of a symptom exists. The bupropion group at 2 weeks, 4 weeks, 6 weeks, and at endpoint did better than placebo at treating sleepiness. However, the SSRI group in yellow did numerically worse than placebo. So, not in a statistical way, but in a numerical way, it almost worsened sleepiness than placebo, with that trend approaching clinical significance at week 4. So at week 4, at the 0.07 level for SSRIs versus placebo. So most importantly, again, bupropion did better than the SSRIs at treating sleepiness in patients with depression. So another very important situation where we have a greater resolution of depressive symptoms for patients treated with bupropion than the SSRIs. The specific symptoms being examined here was sleepiness. So now the question that we all had when we looked at this data, well, our first reaction was this is one of the few instances where you can show one antidepressant is better than another in terms of treating at least some symptoms of depression. But the question that I and some others had as well, you know, we see this slide, and we see that there's statistical significance, but it's hard to picture what that means in terms of patients. You know, how much better is it? Is it some small number? Is it something that's very significant? So we thought of different ways where we could examine the kind of clinical meaningfulness of this finding. You know, what does it mean clinically? And one of the ideas that we came up with was the following. You know, we said to ourselves, well, we know that the SSRIs and Wellbutrin are equally likely to bring about remission in patients with depression, but Wellbutrin is better at getting rid of sleepiness and fatigue. So what if we ask this question? If we look at people that remit with bupropion and people that remit with SSRIs, how many of them will still complain of sleepiness and fatigue? So I think that's a very relevant question that many of you would agree, because it addresses the performance of a drug in the endpoint, because remission is often seen as one of the critical endpoints of treatment of depression. Then comes resolution of a residual symptom, which is a very important measure as well. So let's look at that data. So here we have on the y-axis, we have the percentage of remitters who still complain of residual symptoms. Remitters here are patients who have a Hamilton 17 score of 7 or less. This is standard definition. And on the left, we have sleepiness. On the right, we have fatigue. In yellow, we have SSRIs. In line, we have bupropion. So again, the y-axis, how many people who remitted still complain of a residual symptom? So the more of it you have, the less favorable that is. 20% of patients who remitted with Wellbutrin XL with bupropion, 1 in 5 still complained of sleepiness. 32.1% still complained of sleepiness with SSRIs. So the message here and the difference being statistically significant, if you achieve remission with bupropion in someone, there's only a 1 in 5 chance that they'll still complain of sleepiness. If you achieve the same outcome, remission with an SSRI, 1 in 3 will come to you and say, well, thanks for getting rid of my depression, but what am I going to do about feeling sleepy all day at work? This is an important outcome, because when people are reintroduced into their workforce, they want to catch up with productivity. They've been out of work for some time. The last thing that you want is them complaining that they can't stay awake at work and their productivity is still low. It may arouse, unwanted attention from a boss, from other coworkers who may question whether the patient is ready to reintegrate at work. And this may prove a stressful reaction to patients. So very important to stay on top of this. Let's talk about fatigue, tiredness. 19.5% of patients who remitted with the program still complained of fatigue. 30.2% of patients who remitted with SSRIs still complained of fatigue. So around the same numbers, 1 in 5, 1 in 3. Why is this important? It's important. If someone comes to you and says, well, I'm in remission now, but you know what? I'm tired. I can't do my chores at home. My work is more of a manual one than a mental one, and my coworkers who are carpenters or construction workers or anything physical are saying, you know, hey, this guy, I feel bad for him. He's not pulling his weight. And that makes me feel self-conscious as a patient. Or I don't have energy to play with my kids. My kids see me laying on the couch. They know me to be an active mother or father who would play with them in the backyard. That's no longer possible. So, you know, getting rid of sadness is good, and you can do it with a lot of agents, but this is a very important outcome to think about. There are other examples, too, suggesting that dopamine is very good at getting rid of fatigue. So here's a study looking at, by Ravinder and colleagues, I don't have the exact data, it's only reported as statistical significance, suggesting that if you add methylphenidate to antidepressants, they may not produce a robust antidepressant effect, but they will get rid of tiredness in patients. So there's a link here between dopamine and norepinephrine and getting rid of sleepiness and fatigue. So there should be a few more slides here. Okay. So do we happen to have the slide deck, the slide deck that I had mailed? Is that on the program? Okay. Do we have on a stick maybe the? So okay, all right. So let's do this as people used to do this in the old days, where someone would talk and there were no distracting slides to present. So the next section of the presentation that I want to talk to you about is the following. So we've established that some antidepressants are better than others at treating sleepiness and fatigue. But there are many reasons that people can choose an SSRI and SNRI. You know, there may be comorbid severe PTSD or OCD. Someone may say, well, you know, bupropion, it's an excellent antidepressant, but it doesn't have an indication in treating PTSD, OCD, and several other things. So, you know, but what has an indication is something, let's say, like paroxetine or fluoxetine. I chose paroxetine as first line. Patient has a lot of panic attacks, severe OCD, post-traumatic stress disorder. There's also depression present. So, you know, I'm coming to you, doctor, with a consultation. I gave paroxetine to my patient, went up to 60 milligrams, and the OCD, the PTSD, the panic disorder went away. But there's still fatigue present. So what can I do now? You know, withdrawing the SSRI and starting someone on bupropion is clearly not an option because I'm going to lose the benefit that I had and not gain back the subsequent benefit. So there's several options that one, based on the data, could do. The first is, we had done an open-label study looking at adjunctive atomoxetine. Atomoxetine is a norepinephrine reuptake inhibitor. Is atomoxetine available in the Caribbean and Central America? It's available for ADD, right? We have done one study where we added atomoxetine to SSRIs at usual doses as used for ADD, and we found that there was a greater resolution of sleepiness and fatigue in these patients. Now, that wasn't a double-blind study, but nonetheless, that's what, you know, it's a very interesting finding. So one of the things that I do sometimes is add atomoxetine. There are some studies looking at psychostimulants, particularly oros methylphenidate. This is actually the study here. So oros methylphenidate is an agent that I sometimes use. It has some evidence from the data suggesting that it can resolve fatigue in patients with depression. Bupropion, there's some open-label data suggesting that if you add bupropion, you get a better resolution of depressive symptoms than if you add placebo. By far, however, you know, a lot of these studies are open-label. So, you know, many of you may question, what do we have in terms of double-blind placebo-controlled studies that suggest that adding an agent is more effective at getting rid of sleepiness and fatigue than just not doing anything or switching? The best evidence by far comes from the use of modafinil or Provigil. Now, again, I apologize for not really knowing exactly what's available in Central America and Caribbean. Is modafinil available in your regions?
Yes.
Good. So early in this, you know, I was involved early in the stages of development of modafinil. You know, they did it for sleepiness, not relating to depression, for sleep. They had done some studies for sleep apnea, et cetera. One of the things that they wanted to look at is this something that can help with these refractory symptoms of sleepiness and fatigue? So myself, along with Maurizio Fava, helped them design 2 clinical trials. So the first clinical trial was the following. You know, it took patients who were depressed on SSRIs who still had some depressive symptoms and complained of sleepiness and fatigue. So these patients got 100 to 400 milligrams of modafinil. So those are like the typical doses that are approved for sleepiness. And you know, overall, there was no improvement in depressive symptoms or in sleepiness or fatigue symptoms in patients who received adjunct modafinil than placebo. Then they did a second study where they again enriched the population, but this time the patients had a little bit more symptoms of sleepiness and fatigue and depressive symptoms. This one was published actually by a group, Maurizio Fava, my mentor, is the one who published this study. Again, there was an early separation, so at week 1, there was a greater resolution of depressive symptoms for patients who received adjunct modafinil and patients who received adjunct placebo, but not at endpoint. So there was a lot of deliberation, you know, is this something that can help? Is this something that's not effective? So what we did is we pulled the data from the 2 studies, because it looked like they were similar enough in terms of their design and in terms of their outcome. And we asked the following 3 questions. Does adding 100 to 400 milligram modafinil to antidepressants improve depressive symptoms, sleepiness, and fatigue in these patients? And what we found was the answer for depressive symptoms was yes. So sometimes I tend to use this compound as an adjunctive therapy to antidepressants in patients who don't fully get better with antidepressants. The answer for fatigue was no, again reinforcing that this is a very difficult symptom to treat, and if possible, you're better off targeting it with first-line monotherapy than waiting later on to target it with an adjunctive therapy, or you may try oral methylphenidate, some form of stimulant. Number 3, does it help with somnolence? And with somnolence, it did. So the bottom line is, you know, from the modafinil data, is that if you've treated someone with an SSRI and they've gotten better, so you want to keep the SSRI, SNRI, but their fatigue is still present, one of the things you could do is, sleepiness is still present, one of the things you could do is add 100 to 400 milligrams of modafinil. So that'll probably take care of the depressive symptoms, as well as the sleepiness. For the fatigue, you may have to figure out something else to do. So that is pretty much all the data looking at the treatment of sleepiness and fatigue with patients with depression. Again, you know, it's a very important cluster of symptoms because it's seen to serve as the portal to functioning. So a lot of people say, why in some studies of depression do we have a resolution of antidepressant effects, but we really don't see patients, you know, functioning better? So the depression goes away, but they're still not functioning. There are 2 hypotheses that are probably linked. One has to do with residual sleepiness and fatigue. Another says that maybe it's because executive functioning is not fully restored with the SSRIs. It's another ongoing story. So that being said, and I apologize for the missing 5 slides, guys. These things sometimes happen. You know, hopefully verbally we were able to kind of communicate. And of course, I think we have plenty of time for question and answers. So I'd be happy to take any questions and answers from you on this topic or any other topic relating to depression. Thank you.
Sí, para informarle al grupo que la exposición del doctor Luis Ramírez, que estaba supuesta para la 1, ha sido movida para las 2 de la tarde en este mismo salón, con la anuencia del doctor Ramírez, otro investigador de línea. Así que vamos ahora a contestar las preguntas que ustedes quieran hacerle al doctor Papacostas.
Thank you. Please.
Yo quiero aprovechar que tengo dos preguntas. La primera, ¿por cuánto tiempo se debe dejar el modafinilo? Y la segunda, si el doctor... Okay. Y la segunda pregunta sería si el doctor tiene más experiencia con metilfenidato usándolo para mejorar no sé si la hipersomnia o la dinamia, o con modafinilo. Gracias.
Okay, so the first question, how long do you have to leave an adjunctive therapy in place in order to, so that's a great question. The bad news is that no one has tried to answer this question using data. So no one has ever done a study saying if you treat someone with an adjunct, how long should they stay on that adjunct? So we have to go by clinical practice. My sense of it is the following. If you have attained remission with an adjunct, probably 6 to 9 months of continuation therapy is fine before gradually withdrawing it. Now, when it comes to that adjunct being used for a specific symptom like sleepiness and fatigue, potentially that time period can be lesser. There are two important elements here. The first important element has to do with how effective was it treating the symptoms in the first place. So if the symptoms, whether overall depressive symptoms or sleepiness and fatigue, were completely eradicated, then the time to take away the adjunct is shorter. The second comment I want to make is the most important one. Just like there's a placebo response when you treat patients with antidepressants, there can be a nocebo response when you take them away. So, in other words, just like people get better when you give an antidepressant for reasons that have nothing to do with the drug, principally because they believe they're going to get better, patients can get worse for reasons that don't have anything to do with you having taken away the drug pharmacologically, principally because they believe that they're going to get worse. So the most important thing when you withdraw a drug, the most important thing when you add a drug, is to make sure that you've optimized the patient's ability to believe in you and the drug, that they will help. Adding a drug to someone who's completely pessimistic is not going to work. It's better off waiting until they get better. Similarly, withdrawing a drug when a patient is terrified that it will precipitate their worsening is not the time to do it. It's better to first make sure that they're comfortable with the withdrawal and then withdrawing the drug. That element, as a determinant, is much more important than when you do it. Thank you.
Los pacientes que tienen un trastorno afectivo bipolar, cuando están estabilizados, algunos sienten que están deprimidos o que están más bien, uno los ve como estables, eutímicos, pero ellos se sienten más bien que están por debajo. Ahí tienen una experiencia en el uso de metilfenidato añadido al estabilizador del humor para mejorar esa fatiga o ese sentimiento, esa astenia o adinámica.
Yeah, great question. So this alludes more to bipolar disorder, and I just realized that you had a second question to the previous person who asked the question. I'll answer that as well. To my knowledge, there is no sufficient evidence. So I'm struggling to recall double-blind studies looking at stimulants as an add-on to bipolar. So the answer to is adding stimulants good for bipolar? We don't know. Adding Wellbutrin for bipolar, there were 2 studies. The problem with these 2 studies, one by Gary Sachs and one by Robert Post, The problem with these two studies of adding Wellbutrin to mood stabilizers is that none of them used placebo. So what I can tell you is that it was as effective as adding sertraline, venlafaxine, or dicipramine, although it was less likely to cause switches to mania than venlafaxine and dicipramine. What I can tell you is that if it works, because there was no placebo. So maybe all of it was a placebo response, maybe none of it was. What I can tell you, though, is the following. If you're going to add Wellbutrin to bipolar depressed patients, to their mood stabilizer, by the way, aside from the fact that it's often an off-label intervention, it's not approved by anyone, which we often resort to off-label interventions to get people better. The one thing to know, if you're going to add an antidepressant, I don't know if it's going to work, but it's better to avoid anything that increases serotonin and norepinephrine at the same time, because those are the ones that have a risk of mania. So I would avoid SNRIs and tricyclics. So if one is going to add an antidepressant to people with bipolar depression as an adjunct, I think it would be safest to use either bupropion or SSRIs, SNRIs. Now, the third question, you mentioned modafinil, I think you brought up. There are no studies that I can recall adding modafinil to mood stabilizers to treat bipolar depression. There were 3 studies of armodafinil that were just presented in the US 2 days ago. That's the meeting I'm coming from. One of the studies was positive for armodafinil, 2 were negative. So essentially, when the FDA looked at the data, all 3 studies, they concluded that adding armodafinil is not better than adding placebo to mood stabilizer. So that piece doesn't seem to be effective. And just to go back to the previous speaker, the previous person asked a question, you know, is there any evidence whether adding stimulants is better than adding modafinil? There's more evidence suggesting that adding modafinil helps with sleepiness and fatigue and unipolar depression than adding stimulants. That being said, stimulants have better evidence for treating ADD. So if you have someone with sleepiness and fatigue without ADD, or, you know, it's probably best to add modafinil. If you have someone with sleepiness and fatigue with untreated ADD, you probably want to go with the stimulants. I apologize for missing your question earlier. Next question.
Yes, here. Thank you very much. Excellent presentation. I'm going to give the question and make it in Spanish.
Please.
Sabemos que la depresión es una enfermedad sistémica y que, pero obviamente con otros cambios y es inflamatoria. ¿Qué cree de el uso de T3, la hormona? Ya que muchos pacientes, aún con depresión, a veces el TSH está normal, el T4 está normal, pero esa persona no está convirtiendo de T4 a T3 suficiente o convierte T4 a T3 reverso.
Okay, excellent. Another excellent question. So there is evidence suggesting that adding T3 is an effective antidepressant strategy for people who have not gotten better with, principally with tricyclics. That's where most of the evidence is. No one is focused on looking what happens to their fatigue. In my experience, I find that it has an effect on fatigue as well, but there's no hard data to suggest it. Nonetheless, I use it often in people who complain of, you know, I've gotten better on my antidepressants, but I'm still sad. So I think that's a great intervention. These are for people with normal TSH. Obviously, you would also be right if you said that, of course, if someone is hypothyroid, that's a medical illness, and that's an indication for added thyroid. I would agree with you. Now, you mentioned that depression is a systemic illness because of inflammation. Let me mention one thing. I think that depression is primarily a systemic illness with secondarily brain effects. That's my personal opinion, that it's the brain manifestation of a systemic chronic inflammation. Why do I say that? You know, when we go around and we try to find out what causes depression, we do epidemiologic, biologic studies. So we look at, is it childhood trauma? Is it insomnia? Is it diet? Is it genes? Is it head trauma? So we look at, is it education? All sorts of things. Childhood adversity, lifehood adversity. And we find that all of those things contribute, but contribute a very small amount. So childhood trauma, yes, it's statistically significant, but most people with childhood trauma will not develop depression. So it's very difficult to find the one thing that will almost always cause depression, because this can lead us into understanding the biology of depression. What is the strongest paradigm for developing depression? So, you can take people, because of their hepatitis C, that you treat with interferon therapy. And you can take people who have never had depression, develop within days or weeks a chemical depression that's indistinguishable from major depressive disorder. Interferons are pro-inflammatory. They'll tell you, I feel tired, I sleep all the time, and I'm extremely sad, and I've never had depression in my life. And this started 2, 3, or 7 days after you gave me interferons. In fact, you can prevent this in people who never had depression by giving them antidepressants before giving the interferons. So there's studies, example, of paroxetine that look at this. So what's the lesson here? That if you're looking for a pathway or a mechanism, if you're looking at childhood adversity or insomnia or medical illness, the strongest one is going to be giving someone for medical reasons a pro-inflammatory cytokine. The same thing happens with cancer chemotherapy. So depression, I believe, based on this data, there's strong data to suggest that in many people, it's something that first starts in the body and then manifests in the mind. And that's why people with depression, they're more likely to die of cancer. They're more likely to have heart attacks. They're more likely to have strokes. These are also kind of inflammatory illnesses. So that's a lot of people with depression are kind of coming to this conclusion that it may very well be that there's something going on in the body that's making the mind depressed. Thank you. I think we have time for more questions. Although I do applaud the previous question too.
Este diploma, por su brillante exposición y lo didáctico de la respuesta, usted terminó como los grandes maestros, de espalda a la pantalla. Nuestros grandes maestros terminaban las conferencias sin hacerle mucho caso a la pantalla. Así terminó. Muchas gracias por su exposición. Esta tarde el profesor Papacostas hablará de depresión bipolar. Acuérdense que el doctor Papacostas es especialista en las partes más difíciles de la depresión. Depresión resistente y depresión bipolar. Vamos a ver qué nos trae de nuevo en este segundo trastorno.
Recuerden que a las 2 de la tarde les esperamos con la intervención del doctor Luis Ramírez, otro brillante expositor también. Así que a las 2 les esperamos con el doctor Luis Ramírez. Gracias. Lo que pasa es que el laboratorio ser libre y te cuatro y hacer lo que puedes de la gente lo que tiene, pero aún así hay gente que lo que es más, fíjate que el problema es que todo el mundo buscando el TCA. Lo mismo que lo dijeron, mira, TCA debe ser con tu mamá, que antes nos dijeron que era sexual. Yo soy hijo de tiroidea, soy hijo de tiroidea, y entonces me pasó que no se llamaba. Que te tiene no, gracias. Pero el paciente no baja para yo llevo 20 años en y yo hablaba con una y después se yo que quiero ser primero. Entonces tú ves que la cosa me daba cuenta pues yo tengo todo eso, pues hija, yo estoy así, yo vengo, hay cosas que no consigo, pero normal, pero ya porque ahí vas a poner la energía y después ahora me lo veo el mismo. No lo veo, es el mismo. Yo el ashwagandha y el turmeric lo mando a pedir en internet, que trae estas vitaminas naturales. Ahí pues está, no seguro que la tener Silvia Gaviria de Colombia.
Ahora no está con nosotros, ya sí.
Ya imprimí, la parte mía está bien, el doctor Papacostas lo que también Camero. Lo que sí necesito es saber a qué hora me
Para que le solicitamos a Ingles, mamita, por favor, para que esté tranquila.
Como la hora es tempranita.
Kenia. Gracias.
Porque con el masaje me voy a ir a mañana.
Todavía, tiene el doctor Camero.
Ay, qué bien, la doctora Silvia Gaviria de Colombia.
Muy bien.
De Venezuela.